everyone. Stan and I are both in a sunny London, which is lovely for us. It's not something we get often. It's making lockdown easier. It's an absolute pleasure to have Reach Live. We do this the end of each month. It's going to be something that we continue rolling out in 2021. And it's a great way for me to close up my Friday because I get to speak to some of the brightest minds and some of the most inspirational figures that I've met. And Stan, you can blush, it's a reality. But one thing I'd say is we've not met yet. We've only met virtually. We've not yet met in real life. And I cannot wait until we do manage to meet. But in terms of kind of teeing you up, let's introduce you and introduce you well. So firstly for myself, I'm Reena Sangar. I head up digital health at Ipsos, and we're a global market research and insight agency. So we focus on doing research in digital health, looking at what clinicians and patients are thinking and doing in this space. And one of our privileges and passions is to work with partners. And one of our key partners is Reach Thought Leadership, a non-for-profit which brings together pioneers in digital health around the world who are doing transformational work. And to have Dr. Stanley Shepherd here with us today is truly an honor. And I'd ask Stan to open with first telling you a little bit about his story. How did he get to where he's getting to now, and what is he actually doing in digital health that is so transformative? So Stan, why don't you introduce yourself? Your audio is on the line of the year. Your line's on mute.
How's that? How's that now? Can you hear me now?
We can.
Good. After a year of lockdown and Zoom, we're all still making the same mistake. Reena, thank you so much for your very kind introduction. And Fran, thank you so much for the opportunity to be on Reach Live today. As my mother would have said, I've come the pretty way because my first degree was actually aeronautical engineering. I got that degree and then joined the Royal Air Force and flew as a jet pilot for 7 years, and then left the Air Force to go to medical school at the tender age of 29. In my general practice, in my medical physician assistant practice, we were one of the very first users of one of the really early GP computer systems. And because of my background, I sent lots of letters back to that GP software company saying your software needs a lot of improvement, and everybody was doing the same thing. But my letter said, your software needs a lot of improvement, but here's what I think you should do. And so they got in touch with me, and I became half a day a week consultant to them, then a day a week, then a day and a half, then 2 days a week. And I'm still trying to run my practice at the same time. And that's how it's continued. So I've combined those two careers. So I've been lucky enough to have one strong foot in technology because of the background, and one obviously strong foot in clinical care. And that's been a real benefit to my career. And so that's where I am now, with a foot in each.
So we would call you an early adopter, really. So one of those, we do a lot of research among clinicians on different digital health solutions, and we have those who are very cautious. They want to wait and watch, and they may have opinions, but want to wait and see what their peers say. We have those that are rejectors. They just simply feel like, oof, that's going to just cause me more pain. And then we have, your profile, which, you were actively trying to improve something, and you saw, we haven't got the time to go into the detail, but I know that you saw the potential of technology early on. And let's talk about that. You were clearly getting involved in the GP system. You saw improvements could be made. Where did your journey then take you?
Well, one of the things of putting the computer into the practice is we had data, and we knew what was going on in our practice. And in those early days, most GPs had no idea. So we knew, for example, that our immunization, we knew what our immunization rates were by different age bands and different immunizations. We knew what our cancer screening uptakes of viral smears, breast screenings, and we knew what our uptakes were. And we were able to use that data to improve those uptakes. And then we reached a point when we started to get up into sort of the 80, 90%, when other people started to say, but of course you'll never get 100%. And that was a very thoughtful moment for me. And my answer to that has stuck with me ever since. So my answer was, actually, it isn't my job as a GP to have 100% immunization rate or 100% cancer uptake. That's up to the person, that's up to the woman, that's up to the mother, up to the adult, whether they want the immunization or not. But it is my job my professional responsibility, and I'd say my ethical and my moral responsibility as a doctor to have 100% information. So I need to know not only who has had the screening, but who hasn't and why. Was it because nobody asked them? Was it because nobody explained the benefits? Or did they have misconceptions about the side effects or the consequences? And I realized that my job was 100% information, and you can't do that on a piece of paper. You can do it with a computer.
So how did you go about meeting that?
Well, we had the other guy's computer system, and then we decided we'd develop our own. So we got on to develop our own. And I think the first thing we did, and I think that was the most important thing of all, was to ask ourselves, what does a GP actually do, and why do they do it? From that, you then understand what is the purpose of the medical record, what's the purpose of medical records, and you develop from there. So you need to drive it. The business needs to drive the technology, not the other way around. And technology is, it does wonderful things, but sometimes, we find a bit of technology and we try and find something that it works for. It needs to be the other way around. And in terms of challenges on a GP system, the major pitfall, of course, is the huge breadth of different conditions, of patients, of healthcare professionals. It's an exceptionally broad subject, and a GP needs to understand the essentials of pretty much all of it. So GP systems need to be comprehensive. Then there are the doctors themselves. They all go about their practices in different ways. So the system has to be exceptionally flexible to allow the different ways of working. So combining comprehensiveness and flexibility is not simple. But that system is still used today in 3 countries across a wide range of clinics. So we got there in the end.
So in terms of the learnings, I mean, I love the line you said around be clear about the purpose and then and then develop something. Whereas it does happen, I see it in my role, where people come with a tech and then they're thinking about the application of it, and that's where things really can get unwieldy.
Yeah.
So when you the system, you saw the ingredients of, this is what the job that needs to be done, and these are the needs of the data points that need to be included. How easy was it to bring it into different countries, and what are some of the markets that it is currently working in?
Well, I'd have to tell you that I think the power and functionality of GP systems has kind of reached a bit of a plateau, and we became involved as a global partner to Special Olympics for people with intellectual disability worldwide, and realized that actually alongside the physician systems, there was a huge gap called personal care records for people to have their own data. So we actually made the switch. The GP system is still there, but we knew that having a GP system, we had a comprehensive platform, and we felt very strongly the citizen needed to become the primary data owners. And then we made the switch from physician systems into personal care records for citizens.
Citizens becoming their own data owners, basically.
Well, I mean, you think about it, your own health is the one asset that everybody on the planet has. And not everybody's got a television, not everybody's got a smartphone. But if you like, the only universal consumer product is health, because everybody's got it. And we think that the citizen should be the primary owner of their own health and of their own health data. And our thinking there is that obviously your health is more important than your wealth. And maybe a few people that disagree, but most of us would say that our health was more important than our wealth. And we know that good health doesn't just happen to you. Good health needs to be created and managed just like your wealth. Well, we've all got our own lifelong records for our wealth, yet almost no one has their own lifelong record for their health. What we've got is the scattered information around all the clinics and hospitals we've attended in our lives. So imagine, just pushing the comparison with wealth a little bit further. Imagine what it would be like if every shop you visited and used your credit card in kept their own record of your purchases. And some of them, at the end of the month, sent you that record, and some chose not to. They didn't send you that. How would you manage your budget like that if you didn't have a central record of all that? But of course, that's exactly what we've got in healthcare. We have the transactions with different clinics and hospitals, just like going to different shops, and some of them let you have the information, some don't. So we believe very strongly, and I certainly drive it this way, we believe in all citizens should have their own lifelong record of their healthcare data in their own personal, citizen-held and citizen-owned personal care record. To build that, we thought, well, we've got the platform, but we looked at it from an individual consumer point of view, but we also looked at it industry-wide. And if we took as an example the other great industries that have gone through digital transformation, so you think of banking, retail, travel, insurance, and we identified what were the two key things they had to do to get the benefits of digital transformation. And the first one we came up with is that the industry, not even an individual organization, but the whole industry needed to move from organization-centric thinking and systems to consumer-centric thinking and systems. So if we go back 10, 15 years, 20 years, if I had a bank account with Lloyds Bank in London, I could have another 6 accounts in Cardiff, 12 accounts in Birmingham, and 3 accounts in Edinburgh, all with Lloyds Bank, and they would never know, because all their systems were account-centric, and they couldn't see me across their systems. If I had a car insurance policy with a Prudential and a home insurance policy with them, and I moved home and told the home guys that I changed my address, the car people never knew, because they were policy-centric, and they didn't have a view of me across all their systems. It was a huge painful exercise to change to a longitudinal record for every customer across those accounts, across those policies, and they've done it. Healthcare is still at the organization-centric, stuck at and even the clinic-centric or the hospital-centric. It's not yet got that lifelong record. And for healthcare to get the benefits of digital transformation, they're going to have a lifelong record for each citizen. That's, if you like, the industry-wide one for changing. But the other lesson we took from those industries is that to get the benefits of digital transformation, i.e. greater efficiency, reduced costs, and especially improved customer satisfaction, you must let the consumer manage as many of the services directly themselves as you can. To do that, the citizen has to have their own record and their own lifelong personal care record. So if I order something on Amazon and 2 years later think, I wish I could have some more of those, and I can't remember what the product was called, it's a piece of cake. I go back into my past orders. I've got my own lifelong record at Amazon. Whoop, it's there, click, click, and I've got it again. So I think we took the decision to move from physician-facing records into the world of personal care records, because we think that is the future for healthcare.
And what a challenge. I mean, it makes...
I'll give you that.
Oh, yeah, for sure. I mean, it makes complete sense. I don't think there's one person who's listening into this, or we've met across our paths on these conferences and congresses that we do, that doesn't see it, right? That doesn't see that this is where it needs to go. But it's incredibly tough. It's incredibly tough to get there because of the way data is currently handled in healthcare. So we'll just give a few examples of some of the issues we have around the structure of data.
Yeah. Well, again, I'd say, firstly, it has to be comprehensive. What you need from a personal care record for a newborn baby is different from a teenager or an adult female or adult male, elderly female, someone who does have diabetes or doesn't, someone who has heart disease or doesn't, or lung disease or whatever. So firstly, there's a vast range to a vast range of functionality you need to meet those needs. But also for any one of us, obviously we're all aging all the time. So our lifelong personal care record needs to evolve over our lifetime as we age and as we acquire different conditions. So it's no good. It runs out of steam when I'm 20. It runs no good if it runs out of steam when I'm 40. So it has to be really comprehensive. Secondly, and you touched on this, I think, the data in the record has to come from somewhere. Now, there are going to be, I think, a small number of people motivated enough to add their own data to a personal care record, but that's never going to make the mass market. That's never going to transform healthcare. So you have to be able to extract the data from GP systems or provider systems to populate the personal record automatically. So it needs to be comprehensive. It needs to be automatically populated. We're huge fans of people putting their own data in, but you can't rely only on that. Thirdly, the record has to be proactive. It can't just be a static database. So if your personal care record knows from your GP record that you've got diabetes, we use that to create a personalized evidence-based pathway for you for all the actions that you need to take to get your best health outcomes. And we turn that list of actions into alerts, reminders, and follow up on your phone to ensure that you're unfailingly reminded and followed up for the actions you have to take. It's no good a text coming up and saying you need a blood pressure check. People that doesn't. You've got to keep at it, and it's got to be truly, truly personalised. And in the UK, 80% of the 10 billion that the UK or the NHS spends on diabetes every year could be avoided. 8 billion could be avoided if all UK diabetics got all those regular checks every year. But as it is, only about 58% of them get those checks. So apart from the financial suffering, they're suffering needlessly from the heart attack, stroke, diabetes, amputation that follows poorly controlled diabetes. So comprehensive, the data has to come from somewhere, must be proactive, and I think finally it must be portable. We don't tend to think of this, but you need to be able to take the personal care record with you when you're away from home, and especially when you travel. Today, when we travel, we leave our health and our health records at home, especially if you travel abroad. So if you're unwell abroad, then you've got no records with you at all. But if you've got a personal care record on your phone, and it's multilingual as ours is, a doctor in another country can, with your consent, see your past medical history, see your operation, see your medication, see your allergies, etc., when they treat you. So it is a huge challenge. It's a huge challenge to make it happen. But that's a challenge you have to address. Otherwise, it's just not going to do the job.
Yeah, I completely agree. I think even in other conversations we've talked about such simple things like, let's talk about vaccination. It's the hottest topic.
Yeah.
But how many times, and it's happened to me before, where I'm going traveling somewhere and I don't know if I need a booster or not, if I've had that vaccine. And my goodness, the pain to try and find out it's not easy. It's not a click of a button. It's certainly a few phone calls. And then even that doesn't necessarily wield what I need. And it doesn't make sense, Why don't I have that information accessible to me? So I'm sold. I mean, many of us will be sold. Have you had a lot of naysayers along the way as you're taking on this huge challenge? And what's some of the things that you've had thrown at you as to
Well, firstly, some people say, well, hasn't everyone got one already? Of course, almost nobody has. So I don't know what they think. And I've sometimes, when addressing it, the good old days when you address live conferences, say, please put your hand up if you think your health is more important than your wealth. So all the hands go up. Stick your hand up if you've got lifelong records for your wealth. All the hands go up. Stick your hand up if you've got lifelong records for your health. No hands go up. And I said, just a minute, 2 questions ago, we all agreed that our health was more important than our wealth. So you can, break the ice with a simple 3 questions like that. I think what the naysayers say is you've got huge issues come up immediately, quite rightly, about governance, consent, and so on. Everything we do is with explicit patient consent, not implicit, but explicit. And our consent isn't, I give consent, yes, no. It's I give consent for the data to be used in this way, in that way, in the other way. So you must have explicit data consent. But most importantly, that's why I always say citizen held and citizen owned. That's why the citizen has to be the primary data owner. And so the citizen determines who they share it with, not us. The citizen shares who it's with. And I think people are so embedded with the idea that the doctors will look after you, the nurses will look after you, the healthcare system will look after you. It doesn't. It's not in the collective consciousness that actually maybe you should be doing that. Nobody would say, "I let my bank manage my budget." Nobody says, "I let Next, and Topshop manage my budget." Okay, you say, "I manage my budget." Okay, but we haven't quite got that transition to I manage my healthcare. Things are changing. Lifestyle diseases. The fact that we're all now so accustomed to managing things through our mobile phone. As I said, banking, retail, travel, insurance, we all manage that through our phones now. And I think the statistic is something like 70-odd% of the population book their flights online, and only 2, 3, 4% interact with the National Health Service. Well, what that tells you is there's no issue with public appetite to do this. It's just there's nothing to interact with. So that's the point I made earlier. You've got to be able to manage services directly. Those are the main things. The governance one, that's that needs explanation and reassurance. There's simple things like security, are the messages, are all messages encrypted? All of that is technologically relatively straightforward. But it's I think it's new. It's just people are unaccustomed that I actually could and should have this, just like I do for my wealth.
Let's talk a bit more global as well, right?
Yeah.
So you do hear of a lot of initiatives happening. Like, I'm aware of a lot of work going on in the UAE around the unified health records, and India's been posed as some examples.
Yeah.
What is happening around the globe, and are there any examples that you can point to and say, well, that's really positive?
Yeah. Well, yes, there are, but it's very early days. As you say, many countries are beginning to look at personal care records. In most countries, they say personal care records, but what they usually mean is allowing patients to see the doctor's data, not having it themselves. Of course, there's value in patients seeing the doctor's data, but I think we would recognize that value is quite limited. As a doctor, if I see another doctor's record, then I know what it means. Most citizens cannot, and nor should they necessarily. So we need to display that citizen data in their personal care record in a way that's useful for the citizen, which is different from the way you present it to a doctor, and including the alerts, reminders, and so on I mentioned earlier. But actually, there's an even bigger problem. The biggest problem is that this movement is happening in isolation in different sites all over different countries, in different sites even in the same country. So think back to the early days of ATM cash cards. When if you banked with Lloyd's Bank and you had a Lloyd's cash card, your Lloyd's cash card only worked in Lloyd's banks. And people said, hang on, this is crazy. There's a NatWest Bank outside my office. Why doesn't my Lloyd's card work in my NatWest Bank? And eventually those cards worked across all the UK banks. And then people said, well, look, I'd like to go to France or Spain or wherever for my holiday. Why doesn't it work with French banks? And so slowly, we're now at the position at last where my credit card will work pretty much in any bank anywhere in the world. But it took years to get there. Now, the banks could have thought about this. They could have recognized right at the very beginning that people travel, and it could have been designed to be international from the get-go. But it wasn't. And it took a lot of retrofitting. We're falling into exactly the same trap with personal care records by only thinking locally. In our view, we should be thinking internationally now and multilingually, and we do. So we're looking at early adopters in the UK, US, just recently Brazil, South Africa, and Australia, really not to be smarty boots, but to show that our personal care record platform can work in all those countries for personal care records, despite very different healthcare systems in those countries. Just as my cash card can work despite all the very different banking systems there are all around the world. We solved it. We solved it by making it global. When I say that to some people, they say, well, not everybody travels. Well, of course that's true. But equally, we can still use your card everywhere, and not everybody travels with their credit. Not everybody's going to far off places. But there's no downside to me if I never travel outside the UK, the fact that my card works in other countries. And there's no downside to me if I never travel out the UK, that my personal care record would work in other countries. So I think it is happening around the globe. But as I said, the biggest problem is we're just repeating the ATM card trap again.
Not thinking internationally, thinking locally. And then that's only going to wield us into having to redo a lot of stuff to make it work globally.
Yeah, exactly.
Let's talk a little bit about patient-generated health data. We talk about structured data that's owned by institutions and hospitals, which absolutely, but this huge corpus now of patient-generated health data, which is messy. As someone who works in digital health, when I see some of the biometric data and projects, I'm like, well, what do I do with that? And it's very tough to align it with context and other types of data sources. So do you have any learning around patient-generated health data that you could share?
Yep. I do. And I think we did some early adopters in the UK with hypertension and diabetes. One of the reasons I believe so strongly in the person-generated data is even in the best-run diabetic service, you see the patient 4 times a year, see them quarterly. So for 361 days of the year, the patient's on their own. So when you see them in the clinic, you say, hi, George, oh, your blood sugar's up or your blood pressure's raised. What have you been doing for the last 3 months? Well, George can't remember what he's been doing any more than I can remember what I've done in the last 3 months. And therefore, because you're at the doctor's, your blood pressure's up anyway, so the doctor increases your medication, see you in 3 months, you go back terrified again, and of course your blood pressure's even higher, still so increases the dose of the medication. And because modern lifestyle diseases, hypertension, liver disease, diabetes, your blood sugar going up and down, you don't feel that. There are no symptoms for that. So you don't know when your blood pressure is going up and down or your blood sugar is going up and down until it reaches an extreme level. On the other hand, with person-generated data, if you have your own blood pressure monitor or your own blood glucose monitor, we say to people, look, check your blood pressure regularly, but if you've had a row at home, check your blood pressure. If you've had a lovely walk outside somewhere, you still got me?
You've just gone on mute, Stan.
Right, so my internet just dropped fractionally then. What I was just saying was check your blood pressure. You know, if you forget to take your tablets, check your blood pressure. Then 2 hours later, check it again. And they will only by that person-generated data can the individual start to associate their personal behavior with their personal parameters, okay? And only from that association, oh, when I do this, that's what my blood pressure or my blood sugar does. When I do that, oh, that's better. Only by that association, I think, can the person start to begin to understand what's going on, and from the understanding will come control. And I'd go so far as to say in the absence of that understanding, we're a long way from getting control of these things. So I think person-generated data is going to be critical. And where does all that go? If I'm measuring my blood pressure twice a day, my GP doesn't want that. The logical place for it is my personal care record, and with the algorithms there, we can curate that. And even better still, we can say, you know, doctors spend a huge amount of their time monitoring normal test results. Well, why not let the technology, let your personal care record monitor all the normals and alert you and the doctor only when it's only exception reporting, when something goes outside your agreed limits.
I absolutely love that. You know, it's that, isn't it? It's the context. It's once you know, when you start linking your data changes and interruptions with your life, so you can unlock an insight that can change your life. I mean, love that.
It's a simple feedback loop. It's how we learned as children. It's just a feedback loop. Yeah,
absolutely. Okay, we're coming close to the end. Just 2 minutes left. So why don't you share with us some of your final thoughts from your journey that you're having, and you're currently in a very adventurous one right now. What are some of your final thoughts or things that you'd like to leave the group with?
Yeah, I think COVID has been a terrible tragedy, but it has brought home to people the importance of their own health and the importance of managing it themselves, whether it's sanitizing, hand washing, etc. Simple things, but we've had to do them ourselves, and it's made a difference, okay? So we've kind of relearned, or learned for the first time, that we can make a difference to our own personal health. But to do that, we need our own information to do that. The other big driver, I think, that post-COVID or during COVID is companies. For years, companies have talked about the health of their workforce, not really done anything about it. COVID has shown companies how vulnerable the company is to damage to the health of their workforce. So in our conversations with companies, we see an increasing recognition that they need to look after not just COVID at the workplace, but also their diabetes, their blood pressure, heart and lung disease. And I think we need to build on that to demonstrate that personal care records will lead to a fitter, healthier, and therefore a more productive workforce. So in my final thoughts, Reena and Fran and Reach, thank you so much for the opportunity to put out some of my thoughts on this hugely important area. I really appreciate that. If any of your listeners want to let me have their thoughts too, I'd be delighted to hear from them. I think the day of the personal care record is finally here. I think it needs to be citizen-owned and citizen-held, and so it needs to be citizen-driven. So get out there and start asking for your own. And we look forward enormously to playing our part in helping the citizens of the world to have their own lifelong personal care records. Thank you so much, Reena. Thank you, Fran.
Thank you so much, Dan. Really, really appreciate it. We'll be watching closely, and I hope everyone on the call will be watching closely as you get to your milestone launch. And it's fantastic stuff. And for those that do want to reach out on LinkedIn, please do. or any questions you have, come to Reach Faculty and we can point you in the right direction. So a wonderful Friday, wherever you are in the world. Stan, I hope, like me, you can go out and enjoy the sunshine in a moment.
in bunches of two of us, yes.
Yeah. All right. Thank you so much. Please get in touch with the Reach Thought Leadership team on LinkedIn. If you've got any questions, we can point you in the right direction. Thanks so much, everyone.
Thank you, everybody.